So, we all know annual incidence of idiopathic PH around 0.7 per million. Treatment strategy established in 6th World Symposium of. Yeah. We are using our various treatment strategies there for evolving treatment. I will tell you about to replace trial and patent child trial. That is one of the strategy to use Riociguat. These are the Riociguat study, the replace trial, and this is used in the adult. And these are patent child trial just now came. It is among the pediatric up to the 18 years of age, but it includes 23%. So Riociguat actually it stimulate the soluble guanylyl cyclase, well, you know, and it also increases sensitivity to nitric oxide. It is approved for adult PH and chronic thromboembolic, but dose 0.05 to 2.5 mg TDS. Our objective of our study is to experience of Riociguat on pediatric idiopathic PH. I'll present 3 cases. Our first case is 16 years female, second is 17 years female, and third is 7 years female. So first case, 16 years female, she is known case of hypothyroidism. She diagnosed with idiopathic PH at 9 years of age on view of dyspnea exertion class 2. That time we did cath and it shows systemic PA pressure and no response to NO. So she was on tadalafil and ambrisentan and home O2 for 4 years. But she had gradual worsening of symptoms like failing 6-minute walk distance and dyspnea class 3 to 4. So this time she was planned for IS stenting in view of 1 episode of syncope and decerebrate posturing. But 3 months post-stenting, she had 1 episode of PST crisis. So that time we managed her with inhaled NO. But this time, tadalafil changed to Riociguat and 2.5 mg TDS dose achieved in 2 weeks time after the stoppage of NO. And she gradually improved. Just 24 weeks follow-up we did. So this is before Riociguat, post IS stenting, and these are after Riociguat. Before Riociguat, we found she had dyspnea negation class 3, 4, but after Riociguat, she can climb up to 20 minutes continuous walk and second floor with no syncope. 6-minute walk distance, initially she could not attempt, but later it comes 540 meter with desaturation up to 3%. FC 9 to 22 and NT-proBNP changed from 1,400 to 237. Again, case number 2, she is a 17 years female. She diagnosed at 7 years of age with symptoms and started on sildenafil ambrisentan for 10 years. Then she had worsen of symptoms, dyspnea class 3, recurrent syncope, RV, severe dysfunction, ERVSP 140, NT-proBNP 750, cath shows PVRI 22 and with ionoid into 14. So with multimodality cath it is decided to do port shunt. But what happened immediately in post-operative, 1 week post-operative period, whenever we tried to win up NO, there is desaturation and repeated attempts to extubation also failed. So we started Riociguat and titrated the dose 2.5 mg TDS. Gradually you can taper the NO and discharge her. So after 2 weeks, 24 weeks response for her, the symptoms also improved. She walk distance from 210 meter to 510, and desaturation up to 7%. NT-proBNP 750 comes down to 190. Now third case, she is 7 years girl. She is diagnosed at 2 years of age that in view of PST crisis. That time we did port shunt and followed by she was on tadalafil for 5 years. But last 6 months, she had dyspnea and exertion class 3 and repeated syncope, RV function or severe dysfunction, and TAPS 6, NT-proBNP 550. So this time we tried Selexipag for 2 months, but such symptom reduced but not went down. She had persistence of syncope at least twice a week. So we changed to Riociguat, gradually tapered dose, titrated dose up to 1.5 mg TDS in 2 weeks time. This case we have done 12 weeks response we saw. Previously she had daily syncope, later it no syncope. 6-minute walk distance improved from 70 to 150 and NT-proBNP reduced from 550 to 300. So all 3 cases, there is modest increase of 6-minute walk distance, decrease in NT-proBNP, improvement of functional class and RE function. None of the patient had worsening of symptom. Only one of the patient had a headache at the beginning, but later it's settled. None of them had any hypotension or any pyrexia dizziness. In conclusion, these are limited initial experience of Riociguat in pediatric age group. Changing over to Riociguat seems to be reasonable option in patients who do not respond to phosphodiesterase inhibitors and remain symptomatic. after palliation procedure. So in all three cases, we could postpone the listing for transplantation as the functional status, 6-minute walk distance improved, NT-proBNP decreased. These are the reference I've used. Thank you.
Okay, thank you. So just two questions. Can you tell me the weight of the 16-year-old and 17-year-old?
Sir, in a 16 years old, she has 42 kg, sir. And the 17 years, 45 kg.
Okay, so those two patients, the one little bit of glitch is that by Indian standards, your definition of pediatrics is less than 18 years of age.
Yes, sir.
But if you see the drug dosages of all the pulmonary vasodilators in children, above 40 kg, you can give adult dosage. Okay, so 2.5 milligrams is a standard dose for an adult. Just by age, we cannot, by definition, you are right.
Yes, sir.
It's pediatric age group. But if you see the weight, they should tolerate an adult dose.
Yes.
Okay, so that's one point. Second, how did you determine that for the 7-year-old child, 1.5 milligram TDS was adequate? On what basis did you decide the dose?
Sir, actually, we have decided the adequacy of treatment by 4 parameters. Actually, no worsening of symptoms.
Now, how did you decide that dose? Like you stopped at 1.5 milligram TDS.
Yeah.
So what criteria made you to think that that dose was adequate?
Sir, we have used some the other walk distance.
Shine, I can come in.
30 meter, more than 30 meter. No, yeah, ma'am, I'm telling.
Prashant?
Yeah, Shine. Hi.
You are there. Okay.
Yeah. Sorry. So, it was decided. See, till that time, this patent child study had not come out.
Yeah.
So, how we decided was just on clinical response.
Okay.
So when I started with 0.5 milligram TID, there was a dramatic response. I slowly went up, but till we reach 1 point, after we reach 1.5, her syncope completely disappeared. Okay. So then we thought that we should not go in further because we don't know what the exact dose of Riociguat is. It was just by clinical judgment.
Oh, exactly. But that point I wanted to come out. That's the one point which I wanted him to tell. So it's basically a trial and error method, and the symptom benefit you assessed that this dose would be adequate.
Right. And one more thing, what I would like to bring here is, see, we have tried attempting going from adding Riociguat blindly, in patients who are not responding to sildenafil, but it doesn't always work. In all of these patients, there was some response to nitric oxide. And that is the one which made us think, and in spite of being on phosphodiesterase 5 inhibitors and prostacyclin analogs. Okay. So in spite of being on that, they were having some response to nitric oxide, although not suitable. I mean, does not satisfy the SIT-borne criteria. So we cannot go and start calcium channel blockers on these patients. So only in these patients, we have seen response. Okay. In the other patients whom we have blindly changed over from sildenafil to Riociguat, there has not been so much of a response.
Okay, got the point, Prashant. Thank you for being there. Any more questions?
Yeah, the first case actually there was no vasoreactivity. It was not satisfying the criteria. The only thing is after she came with a PhD crisis, and at that time we managed with INO. It was a very good response to INO. Based on that, we changed over to Riociguat.
Okay, thank you.